the bone underneath it, or proximal arm, distal lower leg, something a little bit better than just kind of straightforward. Your patients will generally say that, and I'll talk about, I'll use general terms as we go through. But as we get into case studies and case presentations and, OSCE stuff, clinicals, you want to be as specific as you can. It is important because a little bit like rheumatology, some of this stuff sounds the same and you really need to differentiate using anatomical terms. If you need to review some of that, I know you have very good information in Bates and foundation stuff has a lot there as well. But the biggest pet peeve I have is laterality. If you don't say left or right, I'm going to scream. Or if it's both, say bilateral. And you can ask the second year students when I grade their notes and they don't put that in, it is highlighted and commentated through the entire thing. It is my pet peeve, but truly a good foundation to have to protect yourself in medical documentation. All right, so this will be kind of a CYA thing as you get into documentation in the hospital, in cases, specifically those that go to surgery, but always document with detail your laterality, even if you're saying it seemingly every sentence. I kind of had a hint about this as we went through some other stuff in the fall, so this is there. And then try to be specific as possible. So, and does it matter? But if you say, patella versus medial third of the patella, that's going to clue me in on one diagnosis versus the other. And that's going to help reorder some of my differentials. So the details in MSK kind of do matter a majority of the time. Okay. I will also say last year, and I don't plan on doing this for your imaging quiz, so you can take one breath of fresh air, but I don't know in the future what this will hold for you. But when I don't even know that was my class, but on a 3-text answer, kind of interpret the image, interpret the x-ray. If that did not start with right or left, they lost a point. So those are the easiest points you'll get. Left, distal radius fracture. Right, scaphoid fracture. Whatever. But always start with right or left. Sometimes in these pre-answer texts, you literally get a point just for writing that. Sometimes you get the point even if you're wrong, right? There were some x-rays last year that were I thought they were a little tricky to interpret for, layman's eyes, or if your eyes aren't really used to telling right from left. So give them a point if they write right or left. I don't care, as long as they're trying. So keep that in mind as we go through MSK. These things are my pet peeves, but I think for good reason. All right, so a little bit of overview and intro. Sprain and strain, are they the same? No. Does it matter? Yes, of course it matters. I just finished saying how all the details matter. All right, do you know what the difference is? One has P and one has T. That is very important to notice because that's how I remember. One is muscle related, one is joint related. So can you sprain your bicep? No. That is a muscle. You can strain it. Can you strain your knee? Not really. You can strain the muscles around it, kind of sprain your knee. So we'll deep dive into that a little bit. How do I remember? It's exactly what Erin said. The difference in strain and sprain is the T and the P. So if you look in the bottom right, your little brain nugget, muscle strains occur in striated muscle. Okay, so you can strain muscle, striated muscle. All right, so a muscle strain by definition is the stretch or a tear of a muscle. People say it's kind of a pulled muscle, I pulled my groin, whatever that is. Usually it's because the muscle gets overly tightened during an activity. So it's usually an explosive power activity, running, jumping, throwing. But sometimes it's, lifting a heavy object, there was someone, you're moving them into their dorm room, whatever. Okay, 1, 2, 3, and that you try to lift really fast, that kind of explosiveness can stretch, tear, strain a muscle. Now, it can become chronic if you keep using that muscle that's irritated. You kind of give it the itis, if you will. But if it's acute, it's much more of that excessive stress, kind of an explosive power thing all of a sudden. And patients usually know that they've done something, right? Oh, they'll stop right away when it's acute. They'll hear a snapping. Sometimes they'll tell you they heard a popping, or they felt that when they, went to lift something heavy. They might get pain, some burning in the same area, or they have trouble even using that area. That's more in the chronic nature, and someone's kind of limping around acutely, but then they come a little protective about it and they limp. You say, how are you feeling? Oh, much better. And they're kind of still limping a little bit. If it's really severe, so a grade 3, a really severe kind of strain or tear of the muscle, you can actually get bruising because you've truly ripped those muscle fibers apart. We know they're red. We know there's vascular stuff there. They can cause bleeding in that area. So if you see a really bad hamstring pull, you'll literally see bleeding right under their butt, and it drains down the whole back of their thigh can look black. Pretty impressive, right? So I don't know that you need to know the details in the grading 1, 2, and 3. I do want you to know that 1 is very mild and 3 is the most severe, okay? So the little words don't really matter to me. Just know kind of the grading. 1 is not much, 3 is more severe. All right. Muscle strains. As we get into joint sprains, right? Joint sprains with the arm, maybe those happen more in sports. So that's kind of how I remember it. I don't care how you remember it, as long as you do. But that's really an injury to the ligament or ligaments around a joint. So ligaments, if you remember 101, they connect one bone to the other. So a tendon is muscle to bone, ligament is bone to bone. That's kind of how we form joints. Now again, this is usually more explosive, right? The sudden activity that kind of twists or tears or stretches the ligament. It could be from a fall. So the mechanism of injury can be very similar here. They'll usually tell you they have the stretching or giving out, that joint gave out at the time of the injury. Have pain, they can't use it, and there's kind of swelling around or near or over whatever joint that is. So when we grade it, same thing. 1 is mild, 3 is severe. Okay? This is your overview, kind of your intro. And we talk about fracture. Any bone in the body can be fractured. Fracturing a bone is the same as breaking a bone. A broken bone is a fractured bone, and a fractured bone is a broken bone. Same. All right, you can use those interchangeably. More of the medical term is fracture, right? So it's not like a fracture is a partial break and a broken bone is a full break. It doesn't work like that. They're the same thing, okay? So the cause can be anything. We said about osteoporosis, osteoporotic fractures. It can be trauma. Patients will usually say, oh, I heard a crack, right? Or I felt it at the time of the injury. And very quickly, they'll have pain, loss of function. You probably can see some deformity. A really gross story. I thought about putting the video on here. I did not because it's quite severe. One of my friends has 2 kids. This was during the pandemic. So I think her daughter was 6 at the time, downstairs playing in their basement, and they have the cameras, they keep an eye on the kids, whatever. 6 and 4, her kids are, and they were playing, and her daughter decided to jump off the side of the couch. So just from the armrest to the floor. And in the video, all you can see is she grabs her leg instantly and starts screaming. So of course she's texting me a picture, or hurt her leg, send me a picture of the leg. I mean, it looks like a leg, right? It's like her shin, essentially. She's like, do you think we should do anything? She's not normally a dramatic kid, I will say that. I was like, She's like, we put some ice on it, feels a little bit better. She won't really walk on it much, but she can, she's 6. So it's like, I feel a little better if you just took her. mostly hinging on the fact that she's not a dramatic child. And sure enough, she had a full-blown fracture in 2 places through her tibia. And if you go back and you turn on the sound to the video, when she hits the floor, you hear snap. You can hear her leg audibly crack. And it, yeah, it was. So in hindsight, going back, you know, she didn't listen to the video with the sound on until they were already in the emergency room. But yeah, long leg cast for 12 weeks, 6-year-old in a wheelchair. That was lovely. I know. So with that, when we find fractures or broken bones, we describe them as medical people as fractures. We try to classify what they are, right? Transverse, straight across, open or compound, through the skin, oblique, displaced, comminuted, all of these. I know you've had these. We talked about this a little bit in AMS 1,000 years ago, but these still exist. All right, if you prefer to see it in words instead of pictures, here you go. I'm not going to get in the nitty-gritty details of this. Generally speaking, we'll talk about some classifications I do need you to know, basically open versus closed, and that basically you can follow the line and understand, generally speaking, what we're talking about. Okay. This should look very familiar. Dr. Harris, again, we've all passed peds, great. So this is really only used in children. You're not going to grade adults in Salter-Harris classification because the physis is closed. So this is pediatric patients only. Probably want to know the most common type of Salter-Harris fracture in children is a type 2. I'm not going to go down digging deep for this. In clinical medicine, we focus on adults 18 and older. We talk about something being dislocated. It's 2 bones that are forced out of position. All right, so complete and forced separation. Usually this is something traumatic. In a small set, this can become a chronic thing, but think of this as traumatic. These patients will have pain, visible deformities, loss of function. You know, we worry about the arterial supply, the vascular supply. So when the bones are out of place, they're probably pushing on something else. It's in a place it shouldn't be. All right. We talked a lot about the itis. Generally speaking, itis means inflammation. Remember that caveat we talked about? Osteoarthritis is a non-inflammatory arthritis. Great. Something that doesn't follow the rules, but generally speaking, we're talking about, you know, the sprain strain that causes, you know, inflammation or the itis, gout, that's crystal induced, right? Autoimmune processes that cause the itis. In MSK, we'll talk about bursitis, tendonitis, arthritis, tenosynovitis. A lot of things in MSK can have the itis, okay? Anybody who's got the itis somewhere will complain of swelling, pain, tenderness, warmth, maybe some mobility issues. So if somebody's got the itis, those are generally the symptoms they're going to come in and complain about. So bursitis, there's, I don't know how many bursts in your body, a lot. So bursitis, inflammation of the bursa, and that can be from a number of things. Trauma, and infections or infectious bursitis. You know, bursa themselves are a fluid-filled sac. I don't know if you remember an anatomy lab. They're not very impressive to look at. You can't really see them. They look very wispy when they're normal, like one thin layer of like spiderweb tissue paper thin, just stuff. Now, when it's inflamed, it can look very impressive, like the knobs on the end of the elbows. The purpose of bursa are to allow tendons to glide over kind of the knobby parts of bone. So a little cushion, a little sac, right? So it can fill with fluid and be a little cushion there. There's major, there's minor bursa, but when that process goes wrong, there's inflammation in there for any reason, that's when you get bursitis. Tendonitis. Again, tendons, ligaments, tendons connect muscle to bone. So a tendonitis usually becomes chronic. It can affect truly any tendon. There's some that are much more common. But usually this is kind of an overuse or repetitive motion injury. When this sets in, again, localized pain, all the itis symptoms, and some loss of function. Can you think of any tendonitis that's common? Which one?
Achilles tendonitis.
Achilles tendonitis, biceps tendonitis, common. What else? Elbow, yes, elbow tendonitis, there's two kinds in the elbow, it's very common there. Yeah, and we'll talk about the details of those, but you know, there's just things we generally know, right? People have had tendonitis, we have tendonitis, it happens, it's very common. Again, we've talked at length about osteoarthritis, but we know this is the breakdown and thinning of the articular cartilage, the joint cartilage, the cartilage that sits on the end of long bones and a lot of bones. So this is the wear and tear, kind of multifactorial. Age is the biggest thing we can correlate with it. But any joint where two articular surfaces come together can end up with arthritis. So CMC, remember that's the thumb, hips, knees, spine, all of those weight-bearing joints. This is asymmetrical arthritis, it's unilateral arthritis, it's non-inflammatory arthritis. Symptoms are exactly what we said, right? Pain, tenderness, worse with a lot of activity, but morning stiffness that improves with movement. How long should that take? Less than 30 minutes, correct. So depending on the grading of arthritis, their symptoms can change. Your hallmark on radiographs are things that we talked about before. Joint space narrowing, which we said, and I wrote, literally less space between the bones. So if you look on one side versus the other, there's less space on one side than the other. Yeah, you see my mouse? Yes. See the space here to here? Looks good. See the space here to here? Smaller. Joint space narrowing. Osteophytes, bone spurs. There's a little guy over here. And then subchondral, under the cartilage surface, sclerosis or hardening, that's a thick white line. Seen this before. Compare, contrast, difference, osteoarthritis, rheumatoid arthritis. I would definitely know that before your quiz. And some general considerations. You know, some of you love MSK like I do. Some of you are still a little skeptical, which I accept. But 1 in 5 of your outpatient visits are going to be MSK related. So skeptical or not, might be a labor of love, but it's going to be in your life. All right. And even if you're not working in, you know, an MSK specialty, your patients are going to have arthritis and they're going to have these things to consider dealing with. All right. So when we talk about it, the first thing we do is figure out, is this something acute versus something chronic? Is this traumatic, like from an injury, or is it overuse, atraumatic? And in probably 80–85% of patients, you can diagnose MSK injuries or pathology from a history and physical exam alone. So we love getting x-rays, we love getting MRIs, but I would argue that you only need those probably 10–15% of the time. So try not to rely too heavily on those, because most of these you can get from a good H&P. And then here, the most important piece of the history, and we get a good history, but the most important piece of history in orthopedics is the mechanism of injury. What happened? So starting with those very classic open-ended questions as you go through your old cards, right? So if we take this and translate it into orthopedics, first thing you want to know, mechanism of injury. What happened? What brings you in today? That's the office, the ER. Hopefully you're not meeting someone in the OR, and hopefully if you do, they're already asleep. All right, but that's kind of our onset. So that's the first thing we want to know, right? Tell me the story. They'll probably tell you in a chronological order and give you most of the things you want to know. But that immediately is going to tell you, is this acute or chronic, traumatic or not traumatic? And that already is going to take your 1,000 differentials and probably cut them in half. All right, so it's a very important thing to get, arguably the most important thing to get. Sometimes patients will come in If it's something traumatic, a fall, an accident, they won't remember. But if they fell, that's gonna set a whole chain of, things in line, differentials, right? So they might have a concussion, they might not remember, you might be using eyewitnesses to tell you. And they can't give you a lot of other history and how it feels. But just to get mechanism of injury, that's very key when you're taking an orthopedic history. Then you want to know, when did it start, duration and timing. They'll probably offer that with your first question. They usually tell you the story chronologically, but not always. So if you don't have that, you want to specify that. Then signs and symptoms, kind of open-ended, right? Well, tell me all about it. And they'll probably give you the location. They might point to it for you as well, visibly. They'll tell you how it feels. That's the characteristics. They'll tell you the severity. They probably won't say, it's a 7 out of 10, right? They're going to say, well, what I can't do. I can't go out and garden. I can't walk on the treadmill anymore. They're going to give you the severity and their quality of life for daily activity limitations. So if you want a severity, put a number to it, but that's how the severity is going to come out for them. If you don't get the characteristics you want through the other stuff, you can ask them more specific and pointed questions. Have you had any swelling in your elbow? Whatever that is. Do you feel like your arm is weak? If you're looking at carpal tunnel. Do you get numbness and tingling at night? You can ask them very pointed questions. And as you build your medical knowledge, you'll kind of already from a history be narrowing down your differentials. You'll use your specific questions to kind of keep ruling things in or out, looking for those classic findings. And then the associated manifestations. Does it make it better or worse? And then in the orthopedic world, have you tried basically what I'm going to try? Anti-inflammatories, rest ice, physical therapy. Ask those things already. Ask them in the history, because 90% of the time, that's where I'm going to go with them. So I can formulate my plan already, knowing what boxes they've checked and knowing what's still available as far as a realistic treatment. The other thing I want to know is, have you tried it? And then how well is it working? Have you taken any Advil? Oh, yeah. Does it help? Yeah, it helps. How much? Oh, on the days I take Advil, I can walk 3 miles for exercise. But on the days I don't, I can't walk, but to the end of the block. That's like, all right, my plan's already forming of this is working and it's working pretty well. That seems like a good thing to keep on board. So, you can ask them and they'll probably give it to you on how much more functional they get with intervention. You can then say, okay, if it's an 8 out of 10 without, what is it with your medication treatment? So a lot of your history can very much shape what's already going on for diagnosis and help support part of your plan. Because sometimes you'll keep it, you'll stay the course, sometimes you'll change it. But a big section of the MSK ties in with review of systems. And there's usually a large neuro component: numbness, tingling, strength, weakness. So every MSK complaint should have that line of review of system questioning. So I think of ROS basically as my associated manifestations, kind of ask all those things up front. But you do want to know numbness, tingling, strength, weakness. That needs to be kind of a big habit. And once we get all of that, we can probably come up with a diagnosis, treatment, and even prognosis for our patient before we've even laid our hands on them. Not that we should be jumping to conclusions, but in terms of being efficient and organizing your thoughts as you go, by the end of the history, you should have a pretty good idea of what's going on. That'll help you narrow your physical exam and focus it down, and then get on to the rest. All right, going into orthopedic thoughts. Just because something is chronic doesn't mean it can't have an acute flare. That goes for George and his rheumatoid arthritis, right? He's had that since he was 31, he's 85. He still has acute flares. That can go with anything in MSK. Same with osteoarthritis. Patients have stuff for a while and boom, acute flare. Sometimes we know why, sometimes we don't. So listen to that in your history and as you're classifying what's going on. You can ask Professor Ohm about how her heel is feeling next time you see her. Think outside of the musculoskeletal system. So again, numbness, tingling, the strength. The downside is we'll talk about specifically, hip pain. or hip pain in a young female. Oh boy, here we go, right? We've got some neuro stuff we should always ask about. We think about rheumatology, even abdominal, GU, GYN. So MSK does lend itself to think outside of the box. You know, we're very closely related to neuro. There's some other things that we do need to keep in mind as we get into specific anatomic body parts. Usually that's going to be hips and spine. All right, the good news for me and what I do is limbs. I mean, I wrote you always, I would say 99.9% of the time you have a comparison, right? So examine and document your bilateral findings. That's where we go, right and left. My research director at my clinic, these are her girls. And they were on the cover of National Geographic a long time ago. The cool thing is same but different. So they're identical twins, right? The picture on the right, you can see them. The picture on the bottom is each of half of their face fused together. When you see it there, you can see they're not actually exactly the same. The other thing I know about them, because I know these girls well, is, let's see, I gotta look. Okay, when you look at the National Geographic cover, Sarah's on the right, Katie's on the left. Sarah's the type 1 diabetic. Same but different. I know, they've been hunted for a lot of twin studies because of this. So they're in the twin community. They're very cool. Super cool. But with that, just like extremities, if you have something, compare it to the other side. You know, you might have their normal, especially if it's a unilateral complaint. So when you say things like, right knee has limited range of motion. Well, part of me thinks, well, how do you know that? I mean, part of me really thinks, document the number. Tell me what it is, 0 to 130, 0 to 110, 10 to 90. Those are all limited range of motions. I want to know the exact number so I can compare limb to limb every time they're coming in. But I also want to say, how do you know that's limited? What's the other side? You know, range of motion 0 to 130, that's pretty good. When compared to 0 to 160 on the left, oh, now I see, that's really good. So that's where the details matter and comparisons come in, not only doing it in your exam, asking about it in your history, but documenting all of those things. Okay. All right, getting into the upper body, lots to cover. I will say, and I think this translated, you guys can tell me, do you see hidden slides when you downloaded this? Yes. The hidden slides are things that I left in there is truly a reference. That will more come from MSK emergency medicine, which is not on the exams tomorrow, so don't do it. That's like down the line. But last year I actually taught MSK in emergency medicine, so I had a lot of crossover slides. I didn't want to take them away. If you want to use them as a reference, great. If they're confusing, leave them hidden and delete them. I am not going to test you on the hidden slides. This is not a trick. Okay. All right. So you can tell which ones are hidden.
How do you know which?
No. As we go through, mine should come up hidden. I will tell you if you don't know. Okay.
Thank you.
I don't want you going down the rabbit hole of crazy things.
Oh, I see.
Can you see?
I
Right.
see now.
Okay.
Download as a
We'll still go
PDF,
through
so
it.
I don't
Just make sure we're
see
clear.
after.
Because a lot of stuff in the other upper body as we go through.
I know.
Some of this is hidden on purpose.
Yeah, I know.
We talk about head and neck,
Except 24.
review anatomy,
Do it as we go
review what's
through.
in there. TMJ, there's one slide on TMJ. This is really a dental thing. A lot of dentists focus on TMJ. This is again, chronic. So as you look through pretty much all of my slides for MSK, you'll see the same layout. Is it acute or chronic? What's the mechanism of injury? Classic signs, symptoms, how to make the diagnosis, treatment, prognosis. That's going to be the repetitive theme as we go through here, all right? So this is chronic. As far as mechanism of injury, it's associated with teeth grinding or bruxism. Common association or cause with headaches. So these patients will get unilateral jaw and facial pain, worse with chewing. Uh-oh, we talked about something else that's worse with chewing today. So worse with chewing versus jaw claudication is different. Make sure you know how to tease that out of your patient in layman term questioning. So how would you ask about jaw claudication prior?
Oop, does it lock up?
You could ask, is it lock up?
Um,
What else? Amy?
Oh,
Oh, gosh. Oh, gosh, she told me.
when you use, like, chew a lot, does it start to hurt a lot more?
Yeah, does it get worse the more you
Mhm.
chew? What other kind of keywords would we ask for claudication? Throughout the day, cramping, fatiguing, yeah. Some clicking. Now clicking could happen with TMJ. That's kind of classic. With TMJ, you'd probably wake up with it sore because the teeth grinding happens overnight. Now with temporal arteritis, giant cell arteritis, that causes jaw claudication. So that's worse with chewing, but it's like you get fatigued from chewing. Usually that's gonna be, if you're eating a salad, do you stop eating the salad before the end because your mouth is just like tired? So claudication in the lower extremity, patients will walk, they'll get claudication in the feet, claudication symptoms, meaning they have to sit down and rest, let the blood flow return, then they can keep going. So the blood flow to the jaw with temporal arteritis is affected. So the muscle, the masseter muscle, that big chewing muscle in your jaw, chew, 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 chew. Muscle needs blood to function and work. There's not enough blood getting to the muscle. It gets tired and it won't work. It's like fatigue. It's like you've done 10,000 reps, bicep curls or bicep stretch. Same thing here. So that's how to ask kind of that fatigability with jaw claudication from temporal arteritis versus a TMJ. Teeth grinding, probably wake up with it, headaches, also unilateral, but they'll have popping, clicking, because this is a mechanical joint problem. So if you look at that picture in the middle where you can see kind of where the true joint is there, it can click or pop. So this is a clinical diagnosis. You may use x-ray. Usually the dentist uses an x-ray to kind of evaluate for this. But you treat this symptomatically, soft diet, NSAIDs. You're going to notice a lot of NSAIDs, a lot of PT, a lot of ice or heat. All right, that's going to be a continuous theme. That's why we ask what they've tried already and how much it's helping. Because that's going to help shape our plan. It's a pretty well-known thing. Everybody Googles, what does it say? Rice. So they do a lot of that on their own. Sometimes they want to see you to confirm diagnosis. Sometimes they want you to help and change something. All right. Usually TMJ is self-limiting. You can see an ENT or oral surgeon. A lot of times you get mouth guards, stuff like that. So you treat the teeth grinding, which then helps the TMJ. It's a lot of popping, clicking. But again, that unilateral, that can sound almost like a giant cell arteritis. So make sure you know how to tease out in your patients, these symptoms of claudication versus classic TMJ. Cervical radiculopathy. This can be acute or chronic. The problem is inflammation or compression of a nerve root in the cervical spine. When you press on the nerve root in the spine, we know that, the periphery, it radiates, it gives radiculopathy down the arm. Now, controversial. My opinion is that cervical radiculopathy is not a diagnosis. It is a symptom of what's happening at the origin point. So radiculopathy is a symptom. You'll see if you go to urgent care, if you go to some orthopedist, they'll write as your diagnosis, cervical radiculopathy. It is an E&M code. That code should only be used until you figure out the exact cause of what's causing that. So try not to think about it a lot as a diagnosis. It's truly more a symptom. It can be a temporary diagnosis as you're figuring out the origin of what's causing the radiculopathy. Does that make sense? Yeah. Now patients will come in and say, oh, I pinched a nerve in my neck. That's what they're going to tell you. That's probably what it feels like. They are going to have the radiculopathy symptoms. So sometimes it's, again, trauma, more acute. Sometimes, especially when you're my age, Ryan can who just had lumbar radiculopathy, right? You just go to sleep and you wake up. That's enough, right? You flipped the wrong way. Your neck was kind of in this mechanical wrong place at night. And you wake up and whatever's happening and the symptoms you have and you don't feel well are radiculopathies. This happens in my neck. It can happen anywhere in the spine, lumbar spine, it's down your leg, whatever. It can also be secondary to other problems. So not common, but could it be a tumor pressing on the nerve causing this? It could. So this can be a secondary symptom of secondary, not true diagnosis. That's why this is more a symptom of something than it is truly the problem in and of itself. So as we get to our physical exam and some of our questioning, we want to say, is it motor or sensory? So numbness and tingling, sensory, motor, weakness. So that's where we're going to tell which side of neuro is involved. It could be both. Classically, your patients who have radiculopathy are going to say they have very sharp, burning, severe, 10 out of 10 electrical pain. And sometimes they won't even take a deep breath because that will be enough to irritate whatever pathology is in the neck and shoot the electrical things down their arm. This will follow a nerve root, so you kind of want to know that distribution. You've known it before, so refresh there. They may have muscle weakness, plus or minus spasms. And then there is a special test on the next slide, the Sperling test. I have never done this to anyone. It is cool. But if it's not so acute, you can do this. But this is definitely a special test to know. All right. To get a diagnosis, we typically start with x-rays. That's kind of an insurance thing. We always start with x-rays, but truly you need to get an MRI to look for nerve root compression. So that's looking at the origin at the source. And then if you're worried about the radicular symptoms and they have the neuro component, sometimes you'll even do an EMG to see how affected the neuro part is as far as weakness. That usually happens if something is more chronic. We treat this 85% of the time conservatively. NSAIDs, ice heat, PT. I've had epidural injections in my neck for something like this, so you can go down that route. Most of the time you can treat it non-surgically.
As far as the EMG is concerned, I've done that before, but when they were doing it, like some lady with like needles that was like.
EMGs are
going-
Bless you.
So an EMG, an electromyogram. Yeah, something, I think that's it. Yes, what they'll do is they take needles and they put them, you see all these different nerve root areas, they'll put them in the different compartments of the muscle with different innervations. And they'll kind of shock and buzz them and they'll see the response from the muscle. So they'll see what motor roots are affected from the compression.
So they're looking for response or not response?
Oh, I read the reports, let's be real. Who knows, Malik? They're looking for how much of a response, right? And it comes out on a graph, kind of looks like a super wonky EKG of your limb or whatever they're doing this for. Yes, they're looking for the response. So is it decreased response means there's a lot more compression? Is that right?
Yeah, or just like not, like I had radio here.
Okay.
Mine and left arm.
Yeah. Yeah, crazy graph.
I know.
Yeah.
What, you know, equipment? Everybody felt like James Bond.
It is kind of weird. My experience with this is when I was working in spine surgery. Once we put patients to sleep, we have EMG, like live neuro monitoring. And it's basically a live EMG throughout surgery. So as we're working on the spinal cord and we're trying to decompress a nerve, we can see, did we get it? Or are we putting too much pressure on a nerve? Are we causing a problem with things? So we'll have live neuro monitoring during surgery. And it probably takes about, it depends what you're doing and who you get. But it can take 30 to 60 minutes just to set that up before you can start surgery. So it's pretty involved, but EKGs, usually that's for this, something more chronic. It's like a palsy where you're not getting, the motor function. And then if this is severe, you can get, oral steroids. You can do steroid injections or again, surgical intervention. That's more rare. Most of this you can treat conservatively. So as far as the special test, here's your Sperling's test. This is super miserable to do someone with acute symptoms, but you'd stand behind your patient. You would extend, and then rotate the neck to the side of the page. So if I have left-sided radiculopathy, you'd extend my neck, turn towards the left side, and then someone would gently apply axial or straight down compression to see if you can reproduce the symptoms. So basically, you're mechanically loading the area that's going to compress. You're actively trying to compress that nerve and see if you can get the symptoms to reproduce. Wouldn't do this if someone just has, spasms and neck pain. This is truly for the radicular symptoms. Don't do this in trauma patients. Don't do this in RA patients with cervical vascular malformations, metastatic disease. You'll fracture right through an osteoporotic vertebrae and just break right through it. This is not commonly used clinically. The only application would be in someone who gets more sporadic symptoms. You're trying to figure out maybe what level it's at, or they can't remember which part of their arm is involved. Maybe you could try to reproduce it, but this isn't something that's actually done much, but something you should recognize as a special test and know what it's for. So, yeah, if somebody came at me when my neck was flaring, I would touch them with my non-affected arm. All right, so moving into the shoulder and the humerus, we have some normal ranges of motion of the shoulder, right? So these you need to know, they apply very specifically to the special test. We're going to get into rotator cuff pathology. There's abduction and adduction. So add is together towards, right? Put it together. So adduction, abduction, flexion, extension, internal and external rotation. With the shoulder and the hip, because it's kind of that ball and socket, this is where it can get a little iffy, specifically when we get to the hip. When you think about internal and external rotation, you're thinking of which way the ball is moving. So internal and external rotation. So internal, external rotation. This makes a lot of sense with the shoulder. Some people with the hips get very confused. Okay, sure. Oh, hide. So those are hidden slides. Good. Did they show up on yours? Like bold or they like muted? Okay, yeah, so make a note. Don't, but you will need to know those for MSK emergency medicine. If you want this as a reference, great. If it's too much, just keep them hidden or sadly say bye to my slides. But that's not Clin Med information. Okay. Why don't we talk about biceps tendonitis? Here we go. Tendonitis, bicep, not a biceps muscle strain. This is biceps tendonitis. So bicep, there's two heads of that bicep muscle. Typically here, we're talking about inflammation of the tendon of the long head of the biceps muscle. Anatomically, if you know where that goes, that's right through the notch in the front of the shoulder. So this is usually, most tendonitis is again, chronic, repetitive overuse. You can listen if patients tell you they had something acute happen. They may actually have a tendon rupture instead of tendonitis. Those are different, okay? Because of the anatomic location of this, in and around the shoulder joint, there's a common association with other shoulder problems, labral tears, rotator cuff tears. So surgically, it's very rare that I do just a biceps tenodesis. Usually, it's rotator cuff repair plus biceps tenodesis. So we're doing these two things at the same time. All right, these patients will have anterior shoulder pain with radiating pain into the bicep. That makes good logical sense. right? If you palpate the bicipital groove, it will be tender. That's right where that tendon lives. That's all inflamed. That's something superficial enough that you can palpate in most patients. All right, they're gonna have pain worse with lifting, pulling, and even overhead motions. So the lifting and pulling makes sense. That's primarily a bicep muscle work. The overhead motion, you do use your bicep to go overhead, but that's usually because the secondary stuff that's also happening. Now, if patients have a true rupture, they kind of get this biceps deformity, which we call a Popeye deformity. You can see that in the picture there. So if we know origin and insertion, right, it goes from here to here, and we lose this attachment, the muscle is strong. It's going to pull and kind of ravel down there. So they have this bulk of their bicep muscle just sitting there. And so it kind of looks like this Popeye muscle. If you look at the contralateral side, they won't do that, much to their disappointment sometimes. Now that only gives, this is backfill information. That only gives, I mean, you lose a little bit of strength without that, but your brachioradialis in the other head of the bicep can do quite a lot of lifting. So a lot of people get it fixed for the deformity alone, or if they really need 100% of their strength, some people don't get that fixed. And it's just kind of a visual thing, but they can still function very, very well. All right, there's special tests for biceps tendonitis, Speed's test, Jurgensen's test. I have those on the next slide. As far as diagnosing this, it's a clinical diagnosis. You can use an ultrasound or MRI to confirm. I'll show you a thickened tendon because of that inflammation. But this is clinical. They'll describe it. You palpate it. Pretty good to go. Conservative treatment. Very rarely do we put steroids in and around an area of tendonitis. Any idea why?
Deterioration.
It's what?
Doesn't it deteriorate the tendon?
It can deteriorate that insertion point. So it could deteriorate, and that makes the tendon more likely to snap or rupture. It's like Achilles tendonitis is a big one. Pretty much never do steroids right there, because if you have an Achilles tendon rupture, that is a major, major problem. You know, here, maybe we're a little more cavalier, because if you do have a biceps tendon rupture, it doesn't hurt anymore. And it's really just most of the time a cosmetic procedure. We'll fix that with something else. So true labral pathology, rotator cuff pathology. All right, as far as the tests, these are how you do it. Speed's test, your elbow straight, kind of your arm and shoulder are extended at 90 degrees with your palm up, and then they'll try to lift against your resistance. So if they have pain right in that bicipital groove, that's a positive test. Jurgensen's test, the elbow will be bent to 90, palm is down, so it's pronated. And they're trying to supinate against your resistance. If that elicits pain in the bicipital groove, it's a positive test. So this is where knowing kind of origin, insertion, and then functionality of the muscle. Basically, if you test or strain the muscle, you know how they work, then you know how to do the test. All right. Adhesive capsulitis. Anybody know what else this is called? Frozen shoulder. Yeah. This is usually something that's slow to onset. It's not like you're going to wake up tomorrow, you slept wrong, and now your arm just is frozen and won't move. So it's a slow and progressive loss of range of motion. It's usually multi-directional. So it's not just reaching, you know, flexing, not just extending. It's kind of a multi-directional slow loss of motion. And the capsule, which are, you know, fibrous ligaments and tendons, becomes inflamed. It causes kind of stiffening and fibrosis. So there's limited mobility there. Now, the thing to know is this is limited active and passive motion. That will be a big differentiator from that and other shoulder pathology. So it's not that they can't move it this way, but I can passively. It's that even if I go to move their shoulder, it won't go. So active and passive range of motion affected. They won't have true weakness like other shoulder pathology. And they're going to have pain that's pretty set in night. A lot of shoulder pain has worsened. Pretty much a clinical diagnosis. Again, We love imaging in orthopedics. We don't need it a lot. Don't need it here. The only time you'd really use imaging is to rule out another diagnosis, like a labral tear, like something else. But again, from your history and your physical exam, you should be able to tease this out without having to do a confirmation. Treat this very conservatively. NSAIDs, PT, or a home exercise program, maybe cortisone injection. You know, it says self-limiting, but this could be for a year self-limiting. So there's kind of these 3 stages of freezing, frozen, and thawing. So this could last for a couple of years, a couple of months. The identical twins' mother had this. She was a volleyball player all of her life. Those twins played volleyball in college, you know, and she got frozen shoulder. Happened to be her dominant arm, which was very difficult, but she did all the things and it just took some time, probably about 18 months. More bursitis, and we name bursitis based on where it is. So subscapular, under the scapula. So this is something, most bursitis is chronic. We can also call this snapping scapular syndrome. Most people don't call it that, but you might hear it that way. Cause some aching, pain, swelling, tenderness, stiffness, kind of those classic itis symptoms. Some patients will tell you they have a grinding or grating, the snapping from the shoulder blade. That's where that secondary term comes in. Again, it's a clinical diagnosis, localizing anatomically these symptoms and where they're coming from. Treat it conservatively. And really, the only time we go after treating something like this surgically is if we're already in the shoulder for another problem. Then we can go out, kind of take out the bursa that's all inflamed, shave it out, thin the bone right above it. But this is not something that is uniquely treated with surgery. Here's an AC joint sprain, so acromioclavicular sprain. This is also called a separated shoulder. You'll hear that a lot more heard, you know, kind of in the NFL, these more traumatic injuries. When you see that guy's upside down, you think it's kind of hard to get like that. It's not when you're playing sports, especially football. So this is a separated shoulder. If you look at the picture in the middle, you can see how one kind of collarbone, if you will, is just sticking up and the other one is not. So you have to find a way to have a direct blow to the top of your shoulder, which is a little strange. So it's usually more of a high speed or direct blow. These patients will have pain and swelling, sometimes a deformity, sometimes not. Discomfort with motion, specifically adduction. So that's when it's under the highest stress. If you kind of adduct or pull their arm down and across their body. You want to make sure they don't have any fractures. So this is when we do an x-ray just to confirm we're not missing anything else. But on the x-ray, you'll just see a lot more space than normal between the clavicle and the acromion process. So again, that's where it's good to compare one side to the other. Rarely surgical intervention. It's a lot more of those conservative treatments, including a sling to kind of hold and pull that down, and everything typically will heal. So again, 1, 2, 3, 1 is mild, 3 is more severe. Kind of a complete rupture. So just a couple more slides. Impingement syndrome. This is a chronic issue from having less space than normal in that subacromial area. Anything come to mind? First glance, what would cause less space there? Arthritis, osteoarthritis, wear and tear. Typically, the ball in the socket kind of be, you know, in. Oh, there we go. Typically, arthritis is here, kind of the articular surface, but there's 2 bones close to each other that can cause it. So impingement, it's just there's not enough space there. So when we look at anatomically what's here, well, here's the bursa. So there's your subacromial bursitis issues right there. That causes a bursitis. Also, here's a supraspinatus tendon. That's one of your rotator cuff tendons. So if there's less space here, probably gonna have some bursitis symptoms, probably gonna have some issues with this rotator cuff tendon as well. So impingement syndrome means when there's less space here, and you go to move, specifically reaching overhead, you know, you need enough clearance, like opening and closing a door, to let that happen. With less space, can't really mobilize that well. So with overhead motions, you get this syndrome, which is usually pinching, pain. It's fairly non-specific. It's associated with bursitis, tendonitis, because of anatomically the structures that live in that area. If you get an X-ray, you'll usually see osteoarthritic changes. First one being joint space narrowing. Then again, osteophyte formation, bone spurs. When you have bone where it doesn't belong, it's going to be irritating that tendon, irritating the bursa, limiting and closing up the space there. All right, you might look for a rotator cuff tear as well, because we know that rotator cuff tendon is in harm's way. Typically, we treat this conservatively, especially as first. Steroid injection maybe to calm everything down. But if this gets severe, you might have surgical decompression. Again, this is usually done when we fix a rotator cuff tear. So once that tendon detaches, fix the rotator cuff, and we'll go and shave off kind of the bottom of the bone there. You leave more space, open up the space, so there's not as much pinching. So that's an impingement. And if you look at tests for this, near test, I remember this, near, you put the arm near the ear, near test, lift the arm, relax it, stabilize their scapula and their shoulder blades, so they can't lift that way. Stabilize that down and have them lift forward, flex the arm with some internal rotation, bicep next to the ear. If they have pain or pinching, something going on, not enough room there. Osteoarthritis, bursitis, tendonitis, something of impingement, something's pinching there. All right, the other test is this. Hawkins-Kennedy, you'll have the patient with a relaxed arm, forward flex their arm to 90, flex the elbow to 90, and then this is me, forcibly internally rotate the shoulder. So you're trying to forcibly rotate, and this is where it gets confusing. This is internal rotation of the shoulder, rolling the ball internally in the socket. If there's pain or pinching there as you kind of load or stress that area, positive test. Okay. I will stop here this morning. Are there any thoughts about what we have